Okay, I'm going to get started. Good afternoon. I want to say hello to everyone. My name is Eileen Bird. I'm the Executive Director here for 2Life, and I'd like to welcome you all to the continuation of our Women's Health Conference program. This is the third in a series of 6 presentations that we are putting on. And if you've got to today, then you notice that we have moved our time. And so we have done that to accommodate our speaker today and to really change it up a little bit. And so I want to welcome people who have joined us for our past talks and people who are brand new and haven't heard any of our education programs. So we're here on Zoom. Each one of you has been joined in, and we cannot see you, and you will be joined in mute, but we will have ways to communicate. So I'm going to get started with a few remarks and things, and then we will invite our speaker, Dr. Stahura, to make some remarks. All right, so for today, I probably, first thing I'd like to do is to thank our sponsors. And so because we do have the support of the community, including the Mona Corporation, the New York State Department of Health, Genentech, and Saratoga Hospital have participated as sponsors and supporters of this particular series. And so we're grateful to them and thank you. And so, you know what, in the scheme of things, we hear, we are all exposed to media in a number of different ways, probably some of our own volition, and some of it just almost seems to come through from osmosis. To be kind to your heart. You hear the words, you see the words in print, and how do we react to that? I see it on your cereal label. And so perhaps you might have only connected heart health with, you hadn't connected heart health with a cancer diagnosis, but our bodies are very complex and full of amazing surprises. Some of them are wonderful and delightful, and perhaps some of the others perhaps might not be so wonderful and delightful.
Eileen?
Yes.
I am so sorry. I do not to interrupt, but I'm getting a lot of messages that something is happening with the link. So I want to, if you don't mind, I could have 2 minutes to try to send this to people who are emailing in. I would really appreciate it. I'm so sorry.
Okay.
But I would like to try to catch them if I can. So give me just a minute.
Let's do that, and then we will jump back on. I'll be right here and wait till you do that.
Thank you.
Okay, so I'm going to get right to it and introduce Dr. Stahura. And so we talked a little bit about questions, and now let's get right to it. So Dr. Stahura is a cardiologist at Capital Cardiology Associates and is spearheading the cardio-oncology team consisting of physicians, clinicians, and medical staff here in the Capital Region. Dr. Stahura graduated summa cum laude from University at Albany with a major in biology and a dual minor in chemistry and physics. She attended Stony Brook School of Medicine and completed her internal medicine residency at Northwell Health. Dr. Stahura received further training in cardiovascular disease at Albany Medical Center and was elected to fellowship in the American College of Cardiology in June of 2018. She is triple board certified in cardiovascular disease, internal medicine, and echocardiogram. Dr. Stahura has also worked as working knowledge of medical Spanish, and I'll let her give a little more detail on that. So with that, I'd like to introduce Dr. Stahura, who has been waiting patiently, and she will share her slides and again, continue sending Q&A in, and I am going to fade off into the sunset.
Thank you, Eileen. Hi, everybody. Nice to meet you. My name is Heather Stahura. Like Eileen said, I work for Capital Cardiology, and I'm sorry, I'm the reason why everybody's time had to be changed. I had to round at one of the local hospitals this morning. So thank you for everybody for being here in the afternoon. Just my 2 cents as I put up my slides about me is I'm so happy to see that Saratoga Hospital sponsored the 2Life. That's actually where I got my start. I was a PCA and cardiac technician over at Saratoga. So kudos to them. Thank you, Melanie, Eileen, Chris, and all the participants for having me today. Let's jump into cardio-oncology. So I love this slide because it's actually old, and it's funny to say something like that because normally people don't put up old slides. But if you see here, and I hope you guys can see when I'm using my pointer here, the number of patients alive with breast cancer, we have over 2.5 million survivors. This slide is old, from 2009. I'm very happy to report that right now it's closer to 3.5 million survivors. And that's really kudos to all the technology advancements and all the new therapies for breast cancer, as well as the doctors, nurses, and all of you survivors out there.
Excuse me, Dr. Stahura, it's Eileen. If I can ask you to try to share your slides one more time.
Oh, it's not coming up. Let me try again.
Thank you.
Sorry about that. How about there, guys? Can you see it now?
Okay. Yes, you're in.
My apologies, everybody. Let me just go back real quick. It wouldn't be 2020, right, without some trouble going on. I said I love this slide because it's actually an old slide. And the reason why I was saying is if you look at it, it's from 2009 down here. And at this time, there was only 2.5 million breast cancer survivors, and now there's over 3.5 million. And again, back on that, kudos to all of you survivors out there, to all the new treatment options and all the fabulous healthcare professionals taking care of, which makes my job coming in the future and talking about cardiovascular health and thereafter even much more important. So what is cardio-oncology? It's kind of a new thing that's come about in the past couple of years because we have so many survivors. It's really the effort to prevent or treat patients with cancer who face heart problems caused by cancer treatments. And the reason why we're so aggressive with this is because, unfortunately, if you're a patient who does have cardiovascular effects from your cancer treatment, there is high mortality. And I'm going to throw a lot of medical terms into here because you're all smart people, and I'm obsessed with cardiology and I love oncology. So I'm going to share my passion with you guys. 60% mortality is extremely high for any condition. So much, and mortality does mean death, just if I have to put those out there for anybody who's not normally used to healthcare terms. So my partner's daughter, it was really cute. We were talking the other day about cardiomyopathy or weakened heart muscles and the heart being very big. And his daughter was very sweet and said, well, that's a great thing, right, guys? Like the Grinch had a big heart and it's Christmas time, right? She was so excited to be like, yeah, that's great that that person had a big heart. Unfortunately, when it comes to cardiology, the larger that someone's heart is has a negative effects. It usually means that the heart is not pumping as effectively or very thick, and over time will have a weakened heart pump to it. So good for the Grinch, but not good for the rest of us. I'm going to go into a case presentation of a patient that I saw a couple of years ago. She's a 60-year-old female. She presents 10 months after diagnosis. I'm sorry, let me just put this down, of her breast cancer. She received a lumpectomy. She had chemotherapy, including adriamycin, Cytoxan, and Taxol. When she came to the hospital, she was extremely short of breath, had very tense lower extremities with pitting edema or swelling down there. She was not saturating well on oxygen. And when we ended up working her up, we found out that she had fluid in her lungs, consistent with a term called pulmonary edema. We then diagnosed her with something called acute systolic congestive heart failure. And these terms, the borderline cardiogenic shock, meant that her heart was no longer further pumping out enough to support her vital organs. And she was almost in a shock-like state from the lack of blood flow. Sorry. This is her initial echocardiogram. So echocardiogram is ultrasound of the heart. I'm going to just show you guys a little bit here. I'll replay this a couple times. This is the left ventricle. This is the major pumping function of the heart right here. These are valves that open and close. This is her aortic and her mitral valve. And as I think you can appreciate, this is not squeezing well. It should be kind of coming in. It's a bullet shape and it should be squeezing inwards, shortening and twisting. Heart's complicated, does a lot of movements. And unfortunately, this was likely secondary to the chemotherapies that she has had to have been subjected to. This is what's called a 4-chamber view of her heart. Again, the ultrasound you can see. This is the major pump called the left ventricle. And as you can see, it's really not squeezing internally and shortening this way, or like I said, remember going from north to south, shortening. We'll play that again. Her right ventricle is over here. This tended to be squeezing pretty well. And these are the atria that collect the blood on the top of her heart. They looked okay. So her valves are okay. It was really the heart pump itself. And unfortunately, this had probably been going on for some amount of time, because what we also diagnosed her with up in the tip of the heart here is a blood clot, which happens when there's stasis of blood and not enough blood flow circulating through, essentially like a scab in the tip of the heart. So what we did for our patient LS is we started her on something called an ACE inhibitor, which a lot of you might be familiar with. They're medicines that sound like lisinopril, quinapril, these prils, and beta blockers. This is the mainstay of therapy for congestive heart failure. We gave her diuretics, which are water removal pills, which helped her to excrete the extra fluid that was subjected and it had backed up into her lungs and into her lower extremities that caused that edema or that sponginess to her skin. Because of that blood clot in her tip of the heart, we put her on a blood thinner to prevent anything like strokes or anything catastrophic happening. Eventually, we ended up putting something in called a biventricular pacemaker, which helped to synchronize her heart and make it squeeze more effectively, and with close follow-up. Happy to report that after 3 months of just intensive, good guideline medical therapy for her congestive heart failure and pushing her with physical therapy, we repeated her echocardiogram and her ejection fraction, or that squeezing potential of the heart, had normalized. So that begs the question, what if we could predict what happened to LS? What if we could do something while she was getting her therapy or thereafter that would maybe check on her and see if this was going to happen and precipitate before she had to come in that shock-like state? Probably over the past, I'd say about 3 to 5 years, we started been doing with anyone with subjecting to cancer therapy pre, during, or post. We use something called strain imaging. So if you talk to a cardiologist or your oncologist, and they may be throughout this term, I just want to educate everybody on it. Again, the heart's tricky because it squeezes 3 different ways. It squeezes internally, in and out. It will squeeze like you're twisting a towel, or torsion. And then what also it squeezes is longitudinally, which I want you to think like north to south on the heart muscle fibers. And what we found through different testing is that before the ejection fraction will decrease, strain will be affected first. So we truthfully use this as a precursor. If you follow with me or one of my colleagues in cardio-oncology, or you might remember from your days of getting your echoes every 3 months, they were likely also checking something called strain prior. We also try to look at patients, and it matters what type of chemotherapy you're subjected to. So a busy slide, but I want to focus up on the left upper top. The bigger medications that I pay attention to and the more toxic ones would be your anthracyclines, your cyclophosphamide, and your Herceptins. You can see docetaxel and pertuzumab or Perjeta is in the intermediate category. And then we really personalize how we look for this. If you have other risk factors, concerning would be if you've had cardiomyopathy in the past and you've recovered from it or still have it. If you've had coronary artery disease or peripheral artery disease, you're at higher risk for this to be troublesome. That's when we're going to watch it closely. If you have hypertension, diabetes, if you've had previous anthracycline use. I've had people who've had anthracyclines in their teen years because they had lymphoma and unfortunately have a secondary tumor many years later. That's twice the amount of anthracycline. We watch them very closely. If you've had chest radiation, which we'll get into further, if you're very young when you have to get your treatment or very old. And unfortunately, ladies, our female gender does put us at higher risk for this. So the monitoring recommendations that you'll see myself and my colleagues do is TTE stands for transthoracic echo, of which you just saw with the squeezing before. We do that with strain, usually every 3 to 6 months. And one of the questions that came in is, well, say I'm done with my anthracyclines, what's that next step? Unfortunately, anthracycline use can cause cardiomyopathy, AKA weakened heart muscle, for very many years after, up to 15 years. So if you have some of these patient-related risk factors that I brought up in that right-hand corner, we normally will check you 1 year with an ultrasound. I routinely see my patients at least once a year because I get a lot out of talking to you and advising how much exercise you're doing and your physical abilities. We usually do echoes 5 years after and then 10 years after to keep monitoring for potential long-term side effects. And again, this is still quite rare, but because has such high mortality, we're very aggressive in watching very closely. If on the bottom of the slide here, you look at if you're at high likelihood or if we have very high concern that you could have a cardiomyopathy because of it, we may institute these protective medications prior to your ejection fraction or your strain decreasing as a protective effect. So that's your ACE or your ARBs, your carvedilol or metoprolol, beta blocker therapy, and statins. So statins get a lot of bad play. And as a cardiologist, I love statins. Let me just throw that out there. They have anti-inflammatory benefit, and there's been multiple studies shown that this helps not only with cardiac issues, but also with cancer therapy, likely from that anti-inflammatory benefit. So let's talk about the future. Where are we going from here? A lot of us will also be using new medication called Entresto. You might see this, it's got big play always on your commercials. Entresto is a dual tablet. It's valsartan, so this is an ARB medication, and sacubitril. This has superior efficacy of protecting and strengthening the heart muscle if it should become weak. And this was one of the landmark papers that showed its use for trastuzumab. I'm not trying to make you guys pharmacists or doctors right off the bat, but really just in case there's any medical professionals who are interested in how does Entresto work. Again, dual medication. It works on the natriuretic system, which you see over here on the left side. These are circulating hormones where it blocks neprilysin, and then it makes these inactive products still circulate, helps you pee out extra fluid, keeps your blood pressure low, decreases your sympathetic tone. Aldosterone, which is a hormone that if it gets upregulated, which it likely does in heart failure, leads to volume retention as well as high blood pressure and further trouble with the heart. And you hear me talk about this all the time, inflammation. Anything that decreases inflammation is so important to your cardiovascular system, as well as for your cancer treatment therapy. And our biggest issue for the heart is hypertrophy or thickened heart muscle or fibrosis or scarring. So this protects on all of that. It also affects the renin-angiotensin system, where it blocks this ATR1. When you block that, you reduce your sympathetic tone, your blood pressure, and again, it works on fibrosis, inflammation, all these cascade of events. So these medicines are not just doing one thing. They're amazing because they hit so many different factors. Very busy slide, but let's just talk briefly about what anthracyclines do to your heart muscle. So the major powerhouse of the cell is called the mitochondria, and that's this guy that looks like a bean down here with all these squiggles. This is the guy that this is the muscle of the muscle. It actually affects the mitochondria, causes dysfunction, and what you see down here at the bottom of the slide, this is a pathology. And mitocytolysis is basically disruption of the heart cells themselves. When you disrupt them even further and cause fibrosis or scarring, it doesn't let the heart communicate to itself. It breaks it down. If it can't beat effectively or communicate effectively, that's when you can have heart rhythm disorders, as well as that congestive heart failure or weakened heart muscle. Also, what we talk about is being the drop in the ejection fraction or the squeezing potential of the heart. So this is a plug for exercise. And you might be thinking, oh, is this one of those doctors who tells me what to do, but she doesn't actually follow her own recommendations? And I don't know if you guys can see, but that's my baby behind me. That's my workout bike. And I actually practice what I preach, okay? This slide right here is just to illustrate the protective benefits of exercise. If you look at the left-hand side, this slide shows the proportion of patients who were surviving without cardiovascular events. If you look at the METs down here, the pre-diagnosis exercise, METs are metabolic equivalents of exercise. The more strenuous the exercise, the higher the METs that you're doing. And you can see in the purple line here, the higher exercise that you're able to tolerate makes people not die as much. It's just, if I could bottle it up and give it into a pill form to people, it's literally heart and body protective. Not only does it starve off things like diabetes as well as Alzheimer's disease, it literally is protective for women or men going through cancer therapy. Just let's talk a little bit about what does radiation to the chest or breast do? Radiation is going to cause things like free radicals, and it increases that inflammation, which we keep talking about is so problematic to the heart arteries. Schematic diagram here. So your heart is this big, wonderful red structure in the middle. The lungs are the purple on the side. This woman's effective breast over here. A lot of the radiation therapists will do a really good job of trying to miss all of the body organs and only focus on the tissue at hand. This does become problematic if it's closer to the lungs or to the heart. Sometimes they can't miss it, but they do a lot of important things to try to spare the other organs. One of the things that we found is very important to do is something called just a deep breath hold. So on the left-hand side over here, when you're looking, this is the effective breast with the bad tissue. The heart is labeled for you here. And you can see if this is the radiation field that they needed to work with, it catches the bottom of the heart. And again, when you have the radiation hitting this part of the heart, it can cause accelerated coronary disease. So one of the easiest ways, if you think about it, is if you take a deep breath open, it pulls your chest wall away from your heart, because your heart stays right here and it's not going to move with the deep breath much. But when you pull your chest out, even if you practice right now, you can watch your chest wall rise. That alone, if you see on the right-hand side here, is able to pull away and actually miss part of the heart that was the issue before, and thereby protecting the internal organs more. Something else that's done frequently, and you should always check with where you actually get your radiation from, but something called prone breast radiation. So supine is when a patient is laying on their back facing upwards. Prone is when you're actually laying face down with your back facing upwards. So putting a patient on prone with the breasts hanging down into the usually there's like a cutout or a lift from what you're actually laying on, and it actually hangs down. So you can see in the middle slide right here, you're missing, here's your red line outline. I'm sorry, it's a little bit faint how it projected, but it misses the internal organs like the heart over in here. And you're really able to focus on just the bad tissue. Again, if you were laying on your back in that supine position, we'd be affecting part of the heart right down here and part of the lung, which could cause cardiac compromise years later down the road. So the improvements of doing it in the prone imaging is you spare your cardiac and lung tissue. This is actually beneficial if a woman has large breasts, because when you lay on your back, the breast tissue will slide to the side, and it could involve more cardiac area if it was on the side. So for larger breasted women, this is beneficial. And basically it also helps with radiation effects to the tissue itself as better cosmesis. What radiation actually does to the heart arteries is it causes this oxidative stress, or you hear these terms like free radicals. It activates a bunch of things which are called cytokines, which are like sirens for inflammation. And when the body has a lot of inflammation affecting it, the body basically thinks that it's been harmed. So if you see in the thing down here, there's a lot of cholesterol that can get underneath the heart artery. And it's really because of this oxidative stress and the free radicals that happen from it. We have found that radiation, it's not immediate, the trouble that happens from radiation to the chest. This is a longer term, it happens usually 10 to 15, 20 years after someone's had radiation to their chest. Again, with breast cancer, we have options for trying to remove and move the breast to the side or prone them, etc. Unfortunately, with people with lymphomas or different things like that, or leukemia patients who have to get total body radiation, this is troublesome because it blasts the whole front of the chest and usually does hit the heart. The radiation can also affect your heart valves. So on the left-hand side, you see a healthy aortic valve of a patient. The valves, I talk about them like saloon doors. They open and close, lets the blood through. You might have heard this, if somebody has something wrong with their valves, it can cause a murmur or turbulent blood flow through. So the valve should look like a sheet blowing in the wind, nice and flappy, open and close easily. The radiation causes disruption, fibrosis, and thickening of the heart valves, and it leaves it like this poor person over here on the right-hand side, where the valve becomes very thick and doesn't open well and doesn't close well. So it ends up being stenotic or tight or regurgitant and leaky over time. The echocardiogram, like I showed you in our first patient LS, this is what it kind of looks like again when you've had radiation. This should be nice and thin, like I said, like that sheet blowing in the wind. Here, this poor person's valve has gotten very thick and calcified over time, and it's also affecting her mitral valve as well too. This is the aortic, that's that left ventricle, and here's her mitral valve. Radiation can also affect the pericardium. So the pericardium is a sac that sits around the heart, and I liken it to like the way your foot is a, you have a foot and you have a sock, right? Your heart is the foot and your sock is a pericardium. They should rub against each other just nice and freely without any discomfort. Radiation to the chest can cause thickening and calcium to be deposited in that pericardium. Sorry, hope everybody didn't have too bad of a lunch, because I know this picture might be a little rough, but again, I told you I'm a nerd and I love it. So this is the pericardium, all thick and white and tougher than it should be. On a CT scan, this might come up as calcium. That's this ring around the heart right here. Calcium shows up on CT scans as white. That's why this person's bone is white and this is white. The reason why this is an issue is it almost strangles the heart. There's nowhere for the heart to beat and to move, because that pericardium is so thick and rigid, it doesn't allow it to do its job effectively. This can lead to congestive heart failure as well too. Risk factors for radiation-induced heart disease is like we talked about. If you've had left-sided chest radiation, if you've had left-sided breast cancers, lung cancers, or you've had to have mantle radiation from lymphoma. If you've had high cumulative doses of radiation, we look at this and we adjust for these for your risk factors when you see us for a consultation. Remember, we talked before, if you're very young at the time of radiation therapy, that's it. It's that it doesn't happen right away. It can happen up to 20 years or so after it can cause trouble. If they had to give you very high radiation fractions, that can be an issue. Again, if the tumors are very close to the heart, they may not be able to spare the heart when they're trying to do the different maneuvers, and it might inadvertently affect the heart a little bit. Back in the way long ago, we didn't know that this was an issue to the heart. So there was no shielding going on. I'm happy to see that most women I see and gentlemen to these days, there's tons of shielding going on and protecting the other organs so that they're not affected. If you've had chemotherapy like anthracycline use, we do know that if you've had cardiotoxic chemo and radiation, the effect is twofold, and it does hurt your heart further. And then you throw in people who already have things like diabetes, hypertension, or known coronary disease. Those are pre-existing risk factors that with the chest radiation can worsen your cardiovascular outcomes. And I think that what part of talks like this I like to do is just to let people know that we're out here and that we preemptively try to look for these things and address them in a timely fashion so that we can most effectively treat them and keep everybody safe. Some other things that can go wrong with chemotherapy or some of the new immunomodulators being used for breast cancer are what's called pericardial effusion. So remember I said your heart is the foot and the sock is that sac that sits around it. Normally they should just rub against each other and just do their thing. If there's fluid that accumulates, it's called an effusion. And remember, the pericardium can only, it's like a balloon, it can only go to a certain amount. If there's too much fluid that accumulates within this space, it can also actually strangle the heart and not let it move effectively and squeeze effectively. This can present as shortness of breath, chest discomfort, or low blood pressure. Luckily, we have so many cancer survivors out there now. And what we do in our cardiac oncology visits is we really assess for your risks from what you were exposed to and your genetic risk factors. So we always know for cardiac disease, there's a genetic side to this. Some people are just predisposed to having early coronary disease, valve disease, cardiomyopathies. There's also environmental factors. This happens to be if you are exposed to other toxic chemicals in the workplace, certain environments. We look into if you've had what chemotherapies you've had, how much radiation, like we talked about before, how many doses for how long of a duration and your age. And then we try to address the other risk factors that we know can keep the heart protected. Tobacco, cut that out, right? That is public enemy number one for heart disease. Obesity and a sedentary lifestyle. Something called metabolic syndrome, which encompasses hypertension, high blood pressure, high cholesterol, as well as inability to tolerate, trouble with glucose, prediabetes, or it's called glucose intolerance. We try to address those, and insulin resistance in certain things like PCOS, polycystic ovarian syndrome, which we'll talk about a little bit later. One of the reasons why, yes, I'm a woman, and I am such a big proponent for women taking care of their health and trying to be proactive, is because heart disease affects all of us women. It does have a propensity for different races and different things that we'll get into, but it affects all of us women. 1 in 8 women will suffer from breast cancer in their lifetime, but 1 in 3 women will die from cardiovascular disease, which is why I'm so passionate about looking for all of these risk factors, mitigating them to try to keep problems away. As you can see from the map I put up here, it's everywhere, but it's really clustered in the Southeast, higher rates of cardiac disease. And again, why does this matter? It's the leading cause of death, like we just said, for heart disease in women. That's a lot of deaths, and many, I worry, could be prevented. 1 in 3 deaths is due to in women is from heart disease, and that encompasses coronary disease, valvular disease, and things like congestive heart failure. Sometimes women come into the office and they tell me, "Oh, it's a man's disease." Oh no, wait, ladies, we are just as much affected, if not more. But only 54% of women, when we look at it, really believe that this is her greatest health threat. The trouble with this, and why I'm so big with prevention, is because women who come to me in the hospital, unfortunately, if someone comes into the hospital with a cardiac event like a MI or heart attack, we're less likely to survive than our male counterparts. So we really have to work on prevention first. Let's talk about some of the risk factors. Smoking. The most preventable cause in women that we can look back at and say, if we could cut that out, we can protect so much more. And it's dose dependent, which means the more you smoke, the more your risk, and for how long of a duration that you're doing it. It goes without saying, but we probably should, is that secondhand smoke also increases risk. I take care of women who worked in a bar, never smoked a day in their life, but back when we could smoke inside, have horrible heart disease because of all the secondhand smoke that they were subjected to. Hypertension or high blood pressure. This statistic actually even surprises me. So 34% of all adults over 20 are defined as having hypertension or high blood pressure. So 34.5% of men, which is around 40 million males, and 33.4, I think my thing got in the way here, which is almost 45 million females have hypertension, which is one of the biggest risk factors of leading towards myocardial infarction, stroke, as well as congestive heart failure in the future. And statistically, women were less controlled than men. They did studies too. If your systolic blood pressure is 185, which is very high, just for everybody in the looking, 130 or greater is high blood pressure. So 130 over 80, I should say, or higher is high blood pressure. So sometimes I see people who haven't checked their blood pressure in years and they're in 185 over 100. That woman has a 3-fold increase of having heart disease over that other woman who checks her blood pressure. We have her on meds and it's now less than 135. So it literally is protective. Hyperlipidemia, also known as high cholesterol. 45% of women over 20 have a cholesterol number over 200, which is considered elevated. Now, if you come to a cardiologist, I don't look at just your total cholesterol number. We really dissect and look down and try to find all of the different numbers like your HDL and LDL. Unfortunately, cholesterol increases after menopause. We do have a slight protective benefit of menopause, which quickly declines after we go through menopause, likely from this. High triglycerides, or your trigs, if people might call them, increase your risk by 37% for women versus 14% in men. This is my plug, this underline here of why statins are helpful. Atheromas or plaque, the size of the cholesterol getting inside the arteries, you have better regression or decline of the plaque with statins than you do with men. And LDL reductions may be greater for women. So this is why I always plug, and I love statins. Physical activity. Sedentary behaviors tend to be more uncommon in women, which ultimately leads to diabetes. If you're diabetic, this removes that protective benefit of heart disease for us women. If you're diabetic, you have a threefold increase of cardiovascular events. There's more MI, mortality, AKA death, stroke, heart failure, or vascular disease. The inactivity further leads to obesity. Women who are greater than 40 BMI have, unfortunately have higher mortality. And your coronary disease risk goes up more so than it does if you were a man with obesity. And again, we'll just touch on that metabolic syndrome. That's hypertension, high cholesterol, abdominal obesity, and excess blood sugar. Women specific risk factors, we talked about these on the side here: the diabetes, smoking, obesity, physical inactivity, hypertension, high cholesterol. But for women, preterm delivery of babies can cause early coronary disease, or it's associated with, I shouldn't say causes, it's associated with it. It's a risk factor I ask you about. If you had gestational hypertension, you're more likely to become hypertensive or have trouble with the heart later on. If you've had gestational diabetes, autoimmune illnesses, most importantly, lupus and rheumatoid arthritis can affect the heart. We've talked about breast cancer treatment, and unfortunately, depression. Depression and anxiety over the long term can increase cardiac risk. Again, people who have hypertensive disorders in pregnancy, we urge them to get screened for type 2 diabetes, cardiovascular disease, which when you see myself and my partners, we do, kidney disease, and eye exams as well too. Polycystic ovarian syndrome, just to talk about this briefly, it increases the prevalence of high cholesterol, hypertension, and diabetes. It causes coronary calcifications, which lead to further, which are markers of cardiovascular disease, and increase your risks of metabolic syndrome and hormonal dysregulation. Menopause, coronary disease, increased risk after menopause, increased risk if you have early menopause, and if we surgically made you menopausal versus you naturally went into menopause by yourself. And it's really due to the estrogen levels. Unfortunately, this did not pan out, the studies that they did. If we give you estrogen back, it does not have more cardioprotective effect, but it causes increase in strokes and clotting. So it's, unfortunately, if we give you it back, it doesn't protect the heart. And just another quick thing, because as a female cardiologist who takes care of a large portion of patients being female, heart attack symptoms do not present always the same as it does do with gentlemen. Very many of women who come in with heart attacks or MIs will have nausea, vomiting, chest pain, inability to breathe, but sometimes we present differently. I always say, women, we don't read the textbooks. We don't always do what we're supposed to, right? It can cause jaw or upper back pain. Sometimes it can feel like indigestion or reflux disease, sweating episodes, fainting, or really shortness of breath is what a lot of my patients say. Inability to carry their laundry up the stairs, inability to chase after their grandkids when they were used to about 6 months ago. Those are changes in symptoms. Plugging to know your numbers, guys, just so we all know what's normal and what's not normal. Blood pressure comes in, we say two things, systolic and diastolic. Systolic is the pressure that your arteries are seeing when your heart contracts. So as you can imagine, your heart has to push against pressure. Keeping your blood pressure low helps your heart to push against a nice feather wall and not a brick wall like high blood pressure does to it. This helps to prevent against congestive heart failure and other things like stroke. Your diastolic number is the pressure of the arteries in between heartbeats. So they both matter. Systolic numbers normal is 120/80. You are considered elevated at risk if you're 120 to 129. With your diastolic being less than 80, and you're actually hypertensive anything over 130. So normally when you get into stage 1, I try lifestyle modifications first with different dietary habits, cutting your salt, increasing your physical activity. And if that doesn't work, I usually soon start antihypertensive medications, because we know, like we talked about further, if we decrease high blood pressure, we protect these hearts in the future. And another plug for just exercising. It doesn't have to be jumping on a bike like I have behind me over there. It can be walking, dancing, gardening, vacuuming, all these other different things you can do too that are pleasurable and enjoyable, that we can try to keep these bodies in motion. Also different ways to reduce stress, because we talked about this. Depression can further cause heart disease. So finding out what works for each of us. For me, it's cooking and listening to music, and that's my stress relief. And obviously taking it out on these bikes and going outside and doing everything that way. Yoga is very good to do, very much benefit with that. But for me, it's definitely music, reading, and cooking. So just to plug again our goals of our cardio oncology program, we want to anticipate problems and give better outcomes for patients with cancer and cardiac issues, provide earlier detection of these toxic side effects, really reduce further damage. When possible, we can reverse it. And ultimately, this is a new field too. We're trying to understand more and work with you and the oncologist team and try to understand further so that we can develop new medications, new protocols, create more research so we can do what's best. This is still a new field. And we want to decrease cardiac disease as a barrier to effective cancer therapy. There are a lot of patients I see that they don't want to give certain medications through, but by just keeping in close contact with good protective medications and good lifestyle changes, we can make them a better candidate for the cancer therapy that they need. And this is what I like to call it is stronger together, because we're both great separately, but together we're stronger together with cardiac and oncology treatment. So let me just put this out here and we can start doing questions.
Thank you, Dr. Stahura. That was fascinating. And you do have lots of questions. They continue to come in. So let's get right to it. The first question I have is, what are the long-term effects of andriamycin years after treatment?
Got it. Can you guys see me okay? I'm sorry, before I do this, I want to just make sure I can. No? Oh, let me see if I can.
We can hear you.
Dr. Stahura, if you can just do stop, maybe you did do stop share.
Did I do stop? Okay, I'm sorry, guys. I apologize. I'm not the best at Zoom.
You're doing great.
How about that? Is that okay? Okay. So the long-term effects of adriamycin, we touched on that during the lecture before. The short-term, what we look at with those every 3-month echoes and watching you is that strain can go down, as well as the ejection fraction, and that's really the strength of the pumping that can happen. To kind of build off of that is the effects can be very long-term. I've seen it, and it's been described in the literature as being during the therapy, within 1 to 5 years after, but we've also seen some people up to 10 years after. That's more rare. Usually it's within the first 1 to 5 years or during the therapy if it's going to happen. But again, with just watching, we can really try to find these different things that could happen.
Great, thank you. All right, have you seen any evidence of a relationship between breast cancer and AFib? This person was diagnosed with both within the last spring.
The answer is yes, definitely, but it's really important to look at the other person's risk factors, because AFib is the biggest heart rhythm disorder that most cardiologists take care of too. So with breast cancer, remember, you also are starting giving some of these medications that can cause that fibrosis or scarring of the heart. That also affects that top chamber, the atria. That's where AFib comes from too. So if you're having some heart changes because of your cancer therapy, it could be affecting that atria top chamber too. But if you also are suffering from things like diabetes, hypertension, obesity, sleep apnea, that could also be a trigger for AFib. So it's important to look at the whole person and not just saying you have breast cancer. Is that what did it? Is there anything else we can look at too?
Perfect. All right, now I have a little more complex question from a listener. If, as a result of breast cancer chemo, I had 2 potentially cardiotoxic interventions, Herceptin and andriamycin, how long might they potentially take to impact long-term cardio health?
Similar to that first question, most of them, the adriamycin is the good thing about Herceptin and Perjeta, if they do affect the heart, very many times we can reverse the effects with those heart failure medications. The answer is that's still up. It can be 5 to 10 years after. It's been reported in the literature up to 15, although that's more rare. So that's, I guess, what we're doing here today too, is saying that with good screening, watching your symptoms for shortness of breath, swelling, chest discomfort, keeping your physical activity up. That's how we can protect the heart. But unfortunately, it can have lingering effects up to 10 to 15 years after you've completed your therapy.
The last part of that question is does age matter in that diagnosis?
Yeah, yes. I think for
Percentage.
for twofold reasons is cardiomyopathies or weakened heart muscle, no matter what happened to more people as we get older than compared to younger. So just being older does increase your risk of that occurring. And it also, we look at things when we get the reports from your oncologist, like how much of the doses of those medications did you get? And if you had to have radiation. So those all together might increase your risk. Again, these are very rare things. Most people who get Herceptin, Perjeta, Adriamycin do not have any cardiac toxic side effects. But it's just being mindful and really just watching and, as I call it, obsessing over the patients, bringing you back frequently once a year and just talking, asking how your activity level is, checking those things like blood pressure, cholesterol, and those echocardiograms to make sure the heart is pumping well.
Okay, and into another area. Are breast cancer survivors who've had AC chemotherapy at higher risk for higher blood pressure?
Not particularly just from that, I would say. I wouldn't blame high blood pressure particularly just on that. There are other medications that can cause hypertension spikes. These new medications called VEGF inhibitors, those cause pretty big hypertension. I think you also have to think is just by nature of us getting older, hypertension is such a big disease that affects women, as we talked about in there. But I don't know that I would blame it just on the Adriamycin or Cytoxan.
Okay, good. Do you recommend getting an echocardiogram after finishing chemotherapy to verify that the heart has not suffered some damage?
If you're on a chemotherapy that does affect the heart muscle, your oncologist may be watching you throughout your cancer therapy. Normally what we do is not immediately after the therapy is done, like say you're done in December, it's usually 6 months after, as long as you're not getting any more toxic medications. Now, if you're having symptoms, none of this matters. You go directly by what the person is saying and you address that. So if you're having shortness of breath, palpitations, swelling, anything like that, we may do it soon after, but normally it's routine to do it 6 months or a year after your therapy's done.
I would imagine a lot of people had that question.
Mm-hmm.
Okay, so next one. I was recently told I have atrial septal aneurysm. I might not be saying that.
Septal.
There
okay.
We go. I'm on Astrazole. I'm not saying that word right.
Anastrozole. Yep, good.
Anastrozole for breast cancer and Synthroid for thyroid cancer. I have not had chemo or radiation. Do I need to take something for blood clot prevention?
No, great question. Anastrozole, though, something I do monitor on my patients on anastrozole is blood pressure and cholesterol levels. So that alone would not be, just being on anastrozole, I would not put you on aspirin. And what an atrial septal aneurysm is the atria sit on top of the heart, the ventricles are the bottom, those are the squeezers. Atria collect the blood. They have normally a septum or a wall in between. It sounds like what you were noted by your echo is a little bit of a bowing called an aneurysm that can be associated with a small hole that was in there. And up to 1/5, 1 out of 5 Americans have this patent foramen ovale in there. That's when I think of atrial septal aneurysm, I think of that. That alone does not mean you have to take aspirin. If there's any concerns, really meet with either your primary or your cardiologist. We assess all your risk factors to know if aspirin is right for you. But just by that alone, I would not put you on aspirin.
Okay, good. The next question. What is the risk if a patient doesn't have chemotherapy, but has radiation and takes an aromatase inhibitor?
Oh, okay. So slightly, again, and I don't mean to be a cop-out, it does matter how much radiation you've gotten and where in the chest, and if there was any of those sparing things that we had done. So if you've had any radiation to the chest that might have hit that heart muscle, like again, if you had lymphoma and you had to have mantle radiation, but if you had right-sided breast cancer and we were able to spare, very, very little risk to the heart. So I think it does matter of where was the radiation, if it could have possibly affected the heart, how much, and for how long the radiation was. Anastrozole does increase, like I said, your high blood pressure. It can affect your blood pressure and it can affect cholesterol levels. So I usually watch those people on a yearly basis to make sure we're treating those risk factors appropriately to decrease your full risk of coronary disease.
Okay, good. Next question. We've got a couple more, and I know I'm being mindful on time. We're getting close to our time, but we had a little delay in the middle. Okay. Are statins okay for someone with moderate asthma?
Yes, yes. So statins, again, like I told you guys, you know how you talk about you love a medications or you love something. I put my own dad on it. I love my father. I would never put him on something unless I truthfully trusted it. Statins, they got some bad play because they can affect your muscles and cause muscle aches and pains. It should not affect your asthma whatsoever. And it's really beneficial because, like I said, it also has anti-inflammatory benefits. When someone comes in with a heart attack to the hospital with us, one of the first things we start is a high dose statin medication called Lipitor, because not only does it reduce your LDL and bad cholesterol, but it decreases the inflammation in the artery. So no, I think with asthma, you should be perfectly okay with that.
Okay. Does extremely low cholesterol have any adverse effects in risk for cardiac problems?
So great question too. It matters. Remember, I told you about what your cholesterol panel looks like. So you have total cholesterol, which is a combination of your HDL, which is, think of that as healthy, H for healthy, low LDL, which is your low density lipoprotein. That's the bad. I call that the lousy cholesterol. So for me, it really matters what's high and what's low. You want your LDL lousy cholesterol to be this low, but you want your HDL to be high. It has a cardiac protective benefit to it. So I'll try to answer this question in two ways. If your HDL is low, that's bad. If your LDL is high, that's bad. Now, let's say I have you on a statin and your total cholesterol is low. Some people, there was concerns that is too low cholesterol very bad? There was a couple of studies that came out that said if you have very low cholesterol, you could affect people's cognition and have trouble with thinking. Subjectively, some patients have told me that, but I'll tell you truthfully, there's been no appropriate studies done that have showed very low cholesterol affects your cognition. We titrate it. If you feel funky, we might change it a little bit, but having low cholesterol because we're making it low is much more beneficial. You need some cholesterol. That's how your cell walls maintain their membranes. So we all need some cholesterol, but we vastly, for most of us Americans, have too much of it in our diet.
I'm sure everybody felt it was good news to have some cholesterol.
Oh, it's good to have a little bit. Yeah.
Okay. All right. So are there long-term heart effects from taking an aromatase inhibitor?
They're very, compared to adriamycin and these other, Herceptin, pertuzumab, all these other ones we talked about that have a higher risk. Aromatase inhibitors do have a very low concern of congestive heart failure with it. So for them, I don't do the 3-month echoes like I do for those high risk medications. But if you're on an aromatase inhibitor, for myself and my cardio oncology colleagues, we usually do check once a year echoes and at least check in with you. And again, it's more about mitigating those risk factors. Is it causing high cholesterol? Address it. Is it causing blood pressure issues? Address it. But again, there is a very small concern of congestive heart failure with it. Very small.
Good. All right. And I think I'm getting to the bottom of the questions. Can you be more, I'm going to talk about estrogen now. Obviously with breast cancer, there's an awful lot of discussion of estrogen levels as being female. Can you be more descriptive of estrogen loss to the heart, as I had estrogen related breast cancer, and because it was invasive breast cancer, I take meds to lower my estrogen.
Mm-hmm. I think that's what's beneficial is if you're in this point of view and you have some of those other risk factors like we talked about, maybe a family history of heart trouble, high cholesterol, diabetes, physical inactivity, you were a smoker. Sometimes what we will do as cardiologists is we'll put you through what's called a coronary calcium score if you have no symptoms at all. And that assesses kind of your risk of cardiovascular disease. I work very closely with the oncologists in the Capital District by trying to find out if there's anything lurking behind the scenes cardiac wise and then treating that, because the goal is not to take you off your aromatase inhibitor if it's working well for you. So I think that there is small side effects of these medications. I mean, we're talking less than 2% for a lot of these things I just talked about, but why not screen for these cardiac issues and address them so you can keep on your aromatase inhibitor that's so beneficial to starve your breast cancer of that estrogen. You're still having some estrogen that will be cardioprotective, but I think it's good to know where you're starting from with that, like a coronary calcium score or stress test in the echocardiogram. Again, I think the risks are quite low, but because there's so many breast cancer patients and survivors, that's why we're just always searching for these potential side effects.
So I think you've opened up a whole new world to us with a lot of different explanations and so forth, and apologize. I think we had some great questions.
Oh, we did.
I think, kind of capitalized on all the material that you shared with us, which was awesome. And so, and a number of really promising slides with some really meaty and juicy information. And so,
sorry, I hope nobody's head hurts after all that, but I told you I love this stuff.
It would be a nice diversion if it was, right? Okay, so anyway, and we've had a number of people join on since you started, so it all worked out, and I appreciate your indulgence in letting us, pause here just for a moment at the beginning. And so with that, I'd like to introduce Melanie McCulley. Melanie McCulley is the Support Services Program Manager here at 2Life, and she's going to say a few words. So thank you. Melanie?
I'm having a heck of a time with my technology. So sorry. Well, I just got, my heart just got a run for its money with that dash to get the link out to everybody. It was pounding so hard. So I'm so sorry, everyone. I will follow up with Eventbrite and find out what happened there. I appreciate those of you who had the link from Friday. That was correct. But we will make sure we take care of that for next time. So thank you for your understanding. And thank you, Eileen. Good afternoon, everybody. I'm Dr. Stahura. You were fabulous. So appreciate the program, wonderful information. And as always, the questions that come out of 2Life's audience, for whatever reason, they are always so on target, interesting, educated. So thank you so much, everyone, for your phenomenal questions. Today's program was the third in our 6-session Women's Health Conference that continues on Thursday, December 17th at 9 a.m. with Dr. Mary Pat Roy. She's from the VA hospital, and she will be talking about bone health and breast cancer. And then we have in the new year, can you believe it, 2021, we have Dr. Jennifer Bremser. She's of SUNY Plattsburgh, and she'll speak on the topic of cognitive health and breast cancer, and that will be January 12th at 9 a.m. And the conference will conclude on January 26th with Dr. Khan from St. Peter's, who will be talking about metastatic and more complex diagnosis of breast cancer. So there's still time to register for the remaining 3 programs. Please feel free to do that and spread the word to anyone else who you think might be interested. In addition to this conference, 2Life continues our regular programming and support services virtually and by phone. And our wig and mastectomy product services continue by appointments with appropriate safety screenings and procedures. Shortly, you'll receive an evaluation for today's event. Your feedback is extremely important to us, so we appreciate you filling that out. I promise you it's very brief. You just have to click through a few items, so we really appreciate if you take a minute to do that. And we hope you're enjoying this 6-part health conference. Our intention is to empower women with impartial information based in evidence and research. And we appreciate your continuing support. So thank you so much and have a wonderful rest of your day.